Hello, so we will begin with our first session. In this, we will study about benign and malignant tumors of the oral cavity. Okay, benign and malignant tumors of oral cavity. So, before beginning with this chapter, we have to know the definition about what is neoplasm or neoplasia. Basically, it means any tissue growth from abnormal along with the normal tissue that persists even after the removal of the stimulus that it has caused is called the neoplasia. Okay, then we will study about what are the benign conditions associated with it. Okay, there are basically four. First of all, it is squamous papilloma, then it is squamous acanthoma, then it is keratocanthoma, and then it is a cell nevi. Okay, so first of all, we will begin with squamous papilloma. Basically, the squamous papilloma is caused with the help of human papilloma virus 6 and 11. You have to remember the virus that is causing it. It's basically asked normally in the Viva or in the case of MCQ pattern. It can occur in any age group. Basically, what are the characteristic feature of squamous papilloma? It is an exophytic growth. Basically, numerous finger-like projections is seen, or you can either call it as cauliflower-like. Okay, finger-like or cauliflower-like projections. Basically, it is painless. It is not associated with any kind of pain. What are the sites that are involved? Basically, it can involve lips, it can involve tongue, it can involve our buccal mucosa. Okay, then what are the common features? Basically, you have to remember what about the squamous papilloma is. It is associated with human papillomavirus 6 and that of 11, and it is an exophytic growth. Basically, it is a cauliflower-like or finger-like projections seen. It is painless. Basic sites are the lips, tongue, buccal mucosa. Okay, or it can either be a palate. It can vary in size. It can either be a few or it can either be a few centimeter. Along with that of this papilloma, we can also found that is called as the common wart or the verruca vulgaris. Okay, wherever there is squamous papilloma, we can also found a condition that is involving the common wart or the verruca vulgaris, and these are associated with human papilloma virus 2, 4 and 40. You also have to remember this papilloma virus involved. In the squamous papilloma, it is 6 and 11, and in the case of common wart or verruca vulgaris, it is 2, 4 and that of 40. Okay, basically, what is a wart? What is a wart? Wart is basically, it is a non-cancerous growth, certainly resembling like a viral infection. Okay, and what is verruca vulgaris? Verruca vulgaris, basically, it is an inoculation, auto inoculation to that of the skin. Okay, it is contagious. So what is common wart? Common wart is non-benign. Okay, it is a non-benign or the non-cancerous condition. The top layer of it resembles like a viral infection. What is verruca vulgaris? Verruca vulgaris is basically the auto inoculation to skin. So what we will see in the histopath of squamous papilloma. First of all, there will be hyperkeratosis. What is hyperkeratosis? Hyper means increase and keratosis is the whitening, keratin deposition हो चुका है. It can either occur due to any kind of trauma, okay, and there will be basilar hyperplasia. Hyperplasia. What do you mean by hyperplasia? Hyper means increased and plasia is the number of cells of the basilar membrane have been increased. Or there will be spinal cell proliferation. Okay. Now this is basically what we have studied about squamous papilloma. You have to remember these 6 points. And more important is about the human papillomavirus involved in squamous papilloma along with that of the common wart and verruca vulgaris. Next we will study about what are coleocytes. What are basically the coleocytes? Basically these are the human papillomavirus altered epithelial cells. This with perinuclear clear spaces and a pycnotic nuclei. Okay. Basically what is the coleocytes? They are basically the HPV altered cells. They have the pycnotic nuclei along with some clear spaces. How we have to treat it? We have to treat it with excision. We can either do it as recurrence of it is rare. Then we will learn about what is called keratoacanthoma. Keratoacanthoma. This condition basically resembles squamous cell carcinoma. Okay, it resembles both clinically as well as pathologically to that of squamous cell carcinoma. Where it is found? Basically, it is a low-grade malignancy. That can be found in the pilosebaceous glands. This is the origin point of the keratoacanthoma. Okay. Then we will study about what is called squamous acanthoma. Squamous acanthoma, basically it is not that much common. Basically it is a reactive phenomena of epithelium rather than a true neoplasm. It is uncommon condition. Okay, you have to learn about it that much only, that it is not so much common. It is a reactive phenomena rather than a neoplasm. Then we will study what is a nevi. What is nevi? Basically it is a condition or a mole. Normally we can see the black spots somewhere on a face, neck or the arms. Basically these are the pigmented cells. Okay, these are called the nevus. Okay, basically a nevi or a mole is a skin condition that composed of a special pigment producing cells that is called as neomelanocytes. Nevi is related to the pigment found that is called melanocytes. Basically nevi is a hematoma. Okay, Then there is a classification that is associated with nevi. In the simple language, you can say what are nevi. Nevi are like our moles that are pigment producing cells, that are the melanocytes. Okay. Then there is a classification that is associated with nevi. First of all, we will study what is skin nevi. There are 3 skin nevi: first, second, and third. First of all is the junctional nevi. Second is the compound nevus, and third is intradermal. Amongst all of them, intradermal is the most common one. Junctional nevi are limited only to the basal cell layer. Compound nevus are found in both dermis plus epidermis, and intradermal is found entire on dermis. Basically, skin nevi can be of 3 types. It can either be junctional, it can either be compound, or it can either be intradermal. Junctional is present in the topmost layer. Compound can be found either in dermis or intradermis, and the intradermal is found entirely on that the dermis and is the most common one. Basically, it is a skin nevi, and what is important for us is the oral nevi. Okay. Oral nevi and skin nevi classification is almost similar, but here it is junctional, compound, and amongst intradermal, here it is intramucosal. Okay. Rest all is same. Here it is intradermal, here it is intramucosal. Okay. Then what is oral acquired melanotic nevi? Basically, it is similar to the nevus that is found on that of skin. Okay. First of all, junctional nevi is seen in the case of infants. Later on, it can either mature to compound or the intramucosal one. 50% of the nevi occurring are intramucosal. Okay. 3 to 6% nevi are either junctional or it can either be that of compound. And rest 25 to 36% nevus can either be of blue nevus. Okay. This is about the nevi what we have studied, classified either into skin or oral. All of them have the same, except in the case of skin it is intradermal, and in the case of oral nevi it is intramucosal. This is basically the percentage contribution of them. Okay. Then we will look about what are the clinical features of nevi. First of all, congenital nevi of skin. What is congenital? As you know, that is from starting or from the birth. Congenital nevi can either be small or it can either be garment. Small nevi have a size between 3 to 5 centimeter, and garment nevi is very large, having a size more than 10 centimeter. Okay. Basically, they are congenital nevi of the skin. They are either flat, they can either be pale in color, or either they can become elevated, with the course of time. 15% occur basically in the case of head and neck region. It is a congenital nevi, that is at the time of birth. And what is acquired nevi? That is within the course of life. Okay. Acquired nevi is basically very common. Acquired nevi, basically age group is between 8 months to 3rd decade of life. That is, acquired nevus can occur from 8th month when you are born up to the 30th year, that is 3rd decade of the life. Okay. They can either be smooth, they can either be flat, or they can either become elevated. But In the case of congenital nevi of skin, here pigmentation can be seen, but here no pigmentation can be seen. Okay, they are basically common. Congenital nevi or skin are mainly seen in head, neck region, and acquired nevi are basically seen in the case of palm, soles, genitalia, etc. Okay, this is acquired nevi. Then we will study about compound nevi. Compound nevi has intradermal along with superficial overlying junctional nevi. Then we will see about spindle, cell, and epithelioid nevi. Basically, this is found in the case of children's. Okay. So we have look about the clinical features about the congenital one. Mostly it can either be small one or it can either be larger one, that is called the garment one. It is found basically in head and neck region. Then we have learned about acquired one. Basically they are found in palm and soles. Then we have learned about the compound one. Compound basically consists of intradermal overlying of junctional layer. And spindle cell is basically found in the case of children. Then we will look about the oral manifestations. Oral manifestations. What are the oral manifestations? It basically the nevi occur more in the white people or fair skinned people as compared to that of the dark skinned or the black. Okay, white percentage of it occurring is 55%. That is higher as compared to that of the blacks. Okay, mostly the lesions are asymptomatic, or then what are the differential diagnosis of that of the nevi? That it can be mistaken with another of the conditions. It can either be that of any of amalgam restoration in the mouth, it can be mimicked with that of the nevi, or it can either be physiologic ethnic pigmentation, or with a person who is smoking, that is smoker melanosis, that is darkened gingiva in the anterior region we can see, or it can either be of amalgam tattoo. Okay, and what are the histological features? Basically, where are the nevi derived? Basically, the nevus are derived from the neural crest cells. Okay, the nucleus of it is basically dendritic. Okay, they can either be large, it can either be round, it can be flat, it can either be spindle shaped. Okay, and then we will learn something about where in the top we have studied about the junctional nevi. In the case of junctional nevi, we can see a basic condition that is asked in the viva, that is called drooping of effect. Drooping of effect, or it is also called as uptroofing effect. You can spell any way you want to spell. You have to remember this drooping of effect or the uptroofing effect. Okay, what does it means? It means the cell, the nevi that crosses the junction and it grows down to that of the connective tissue. This is asked. Nevi that grows down and go to the connective tissue. Okay, basically this is the nevi. Okay, you have to remember this in the case of junctional nevi. Okay, then I have somewhere mentioned about the blue nevus. As you can clearly see, let me, here I have mentioned what is blue nevus percentage. It is 25 to 36%. Blue nevus can be of two types. Here the blue nevus can be of two types. It can either be common blue nevus or it can either be cellular blue nevus. Okay. Then what is the treatment of that, the nevi? Normally, as we see in our body, that we don't remove the nevi, but under what conditions we should recommend to remove the nevi? When there is some irritation during the wearing of the clothes or any belt, and removal of it depends upon the size. Like when there is a large mole present on the body, it's anesthetic, we want to remove it. Okay. And all, if the nevi is found in our mouth, then we should excise it. Okay. And amongst all the nevus, that's make the congenital nevi has highest chance of malignancy. It is the highest chance to become cancerous. Okay. So basically this is all about nevi. What is nevi? Basically it is a pigment producing the mole or the melanocytes. Classification, we have studied it, skin and that the oral. And clinical features about congenital, acquired, compound, along with oral manifestation and differential diagnosis and treatment plan as mentioned above. And you have to remember, it is basically asked what is a proliferative marker. Proliferative marker of the proliferative index, it is Ki-67. During my college I was also asked about this, so I mentioned here. So basically this was brief about nevi, keratocanthoma, coleocytes, squamous papilloma, and what are the benign conditions associated with it. Now we have to start about what are the important things. We have to know basically the definition about what is a pre-malignant lesion and a pre-malignant condition. It is the most important question that you will be asked in theory as well as in the case of viva. You have to remember the definition as such. There is no if, no but. You have to write as such and you have to tell to the examiner as such only. Pre-malignant lesion was described in the year 1978 by WHO as a morphologically altered tissue in which cancer is more likely to occur than in its apparently normal counterparts. Okay, you have to remember this definition as such. Pre-malignant lesion was discovered in the year 1978 by WHO as a morphologically altered tissue in which cancer is more likely to occur than in its apparently normal counterparts. And what is a pre-malignant condition? Pre-malignant condition is a generalized state of the body associated with significantly increased risk of cancer. Okay, you have to remember both of these definition as such, as it is very important. Then we have to know what are the conditions associated with pre-malignant lesion as well as the pre-malignant condition. First of all, what are the pre-malignant lesion conditions associated with? First of all, it is a leukoplakia, then it is erythroplakia, and then it is palatal changes associated with reverse smoking. And then what are the conditions associated with pre-malignant lesion? There are basically the 7 conditions. You have to remember all of them, as it is a theory as well as a viva question. First of all, it is a OSMF, that is oral submucosal fibrosis. It can be syphilis, it can be lichen planus, it can either be discoid lupus erythematosus, it can either be epidermolysis bullosa, it can either be iron deficiency anemia. As all of you know that iron deficiency anemia is associated with a syndrome, or you can call it a syndrome, that is siderophenic dysphagia. Or it can either be xeroderma pigmentosum. Three conditions are associated with pre-malignant lesion, that is leukoplakia, erythroplakia, and palatal changes associated with remorse smoking. And 7 conditions are associated with pre-malignant conditions. It can either be OSMF, it can either be syphilis, it can either be lichen planus, it can either be discoid lupus erythematosus, epidermolysis bullosa, iron deficiency anemia with the syndrome of it associated, that is sideropenic dysphagia, and xeroderma pigmentosum. Okay, so basically you have to remember all of this very thoroughly. This is very important. Okay, so then we will discuss about, today we will only discuss about the leukoplakia. Leukoplakia, other name, it is also called as leukokeratosis. Okay, you have to remember its definition as such, it is very important. What is leukoplakia? It is a white patch or plaque that cannot be clinically or pathologically differentiated into any other disease and is not associated with physical or chemical causative agent except use of tobacco. My handwriting here may not be good because I'm using my, not frequently using my tab, that's why. I think all of you can manage with it. Basically, what is leukokeratosis or the leukoplakia? It is a white patch or plaque that cannot be clinically or pathologically differentiated into any other disease and is not associated with physical or chemical agent along except the use of tobacco. Basically, it is a white lesion that is caused mainly because of tobacco. As we know that leukoplakia is a white lesion, then we will know what are the other white lesions. What are the other white lesions? It can either be candidial leukoplakia, it can either be hairy leukoplakia, or it can either be tobacco induced white spot lesions, okay, or it is smoker's palate. This hairy leukoplakia is associated with a lesion that is called Greenspan lesion. One here is Greenspan lesion, and another condition is Greenspan lesion. You have to remember it carefully. With hairy leukoplakia, it is Greenspan lesion, and Greenspan lesion is associated with lichen planus. It involves a triad, that is diabetes mellitus, hypertension, and lichen planus. So these two lesions you have to remember it separately, that lichen planus is associated with Greenspan lesion and hairy leukoplakia is associated with Greenspan lesion. Okay, the rest we will study in next class. So thank you for watching, and please give your support and do give your remarks if you want to say something or you want something change in it. Thank you so much.